Hi all, my name is Tim Jen and I'm a regional anesthesiologist at St. Paul's Hospital in Vancouver. Today's topic is regional anesthesia for total knee arthroplasty, a narrative review. There has been an increase in the number of knee arthroplasties over time, and specifically in Canada, over the past 5 years, there has been a 22.5% increase. 99.3% of these are due to degenerative arthritis. 87.4 are total knee arthroplasty as opposed to partial knee arthroplasties, and on average, each primary knee replacement costs $9,046. In addition, the type of care has been changing as well. Over the last 5 years, there has been a 180% increase in the number of outpatient day surgery knee replacements. Even though this is still a small proportion of the total number of knee replacements, this is an important trend. In addition, the length of stay has been decreasing over the past decade as well, with a median length of stay of 4 days in 2010 to a median length of stay of 2 days in 2019. So what are we trying to achieve with total knee replacement? In the early phase, we're trying to achieve enhanced recovery with decrease in pain, facilitation of early mobilization and physiotherapy, as well as a decrease in complications. These may in turn have a secondary benefit of decrease in length of stay, cost, as well as resource utilization. The goals for late phase are patient-centered, such as improvement in long-term functional outcomes, decrease in the incidence of chronic pain and chronic opioid use, as well as improvement in patient satisfaction. So how does regional anesthesia play into all this? We'll first examine regional anesthesia's effect on acute as well as chronic pain. Important innervation to the knee include the branches of femoral nerve, sciatic nerve, obturator nerve, as well as the lateral femoral cutaneous nerve. These include the terminal branches to the cutaneous, osseous, and muscular sensory distribution, and these are all originating from the lumbar and sacral plexus. Looking at the knee joint itself, we can see that the articular branches to the anterior knee capsule originate from either the femoral nerve or the sciatic nerve, with minimal contribution from the anterior obturator nerve. As for the posterior knee capsule, the articular branches are from the sciatic nerve or the posterior obturator nerve. A typical course of the total knee arthroplasty include the following steps: midline incision, medial arthrotomy, medial dissection, excision of soft tissues such as infrapatellar fat pad in this case, as well as the cruciate ligament and menisci. And finally, tibial and femoral osteotomy to shape these bones to fit the knee prosthesis. Post-TKA, the pain is usually somatic in nature, but in 6 to 11% of the people, it can be neuropathic at the incision site. The location is usually anteromedial with some posterior knee contributions. The posterior pain usually attenuates before the anteromedial pain. Movement exacerbates pain, and severe pain can interfere with rehabilitation. This is important because decreased rehabilitation results in stiffness and immobility, whereas early rehabilitation improves functional outcome. The pain usually decreases gradually between postoperative day 1 to 3. Preoperatively, 8% of the patients were on opioids, and after the first 3 days, the incisional pain usually decreases gradually, whereas the pain at rest and at movement peaks for around day 8 to 30 and then gradually decreases. 1 year out from the surgery, you can see in the dark bar that most patients achieve a status of no pain, which is great because that means that the total knee replacement has worked. But unfortunately, 35% of the patients still have some degree of chronic pain. In addition, this chronic pain actually impacts patients' enjoyment of life, mood, as well as sleep. And at 12 months, 8% of the patients remain on opioids. So how can we identify these patients who might be at increased risk of chronic pain? Risk factors include preoperative knee pain, pain at other sites, catastrophizing, and mental health illness. And there is substantial data to suggest a correlation between severe acute pain and chronic pain. So how can regional analgesia help with this? From the neuraxis all the way to local infiltrative analgesia at the knee, there is a wide plethora of blocks that one may perform for total knee replacement. As a result, there has been a wide variety of randomized controlled trials comparing one block to another, and therefore reaching a firm conclusion on how one block relates to another is difficult. Thankfully, in 2017, Turkawi et al. Published a network meta-analysis of 170 randomized control trials, and they reached a conclusion that blocking multiple nerves was preferable to blocking any single nerve, and rehabilitation parameters remain markedly understudied, and we'll get into that later. So how does one define the optimal regional analgesic technique for TKA? Turkawi et al. Defined it as one that best balances low pain score, low opioid consumption, and large knee passive range of motion during the initial 72 hours post-op. The results are summarized as below. There is pain at rest, pain with movement, opioid use, and passive range of motion. The blocks are ranked from the best performing to the worst performing for each outcome. In summary, a combination of femoral and sciatic nerve blocks performs the best, including passive range of motion for 72 hours. Femoral nerve block alone is less effective than when combined with other blocks, such as sciatic or obturator nerve blocks. Femoral nerve block results in less opioid consumption than periarticular infiltration. Placebo or systemic analgesia yields poor results in all categories. Obturator nerve block in conjunction with other blocks offers additional analgesia, but obturator nerve block in itself yields poor results. So how about catheters versus single-shot femoral nerve block? In 2014, systematic review and meta-analysis shows that femoral nerve block catheter does provide less pain at 24 hours as well as less opioid consumption. However, more recently in 2020, the result is not as clear, with the systematic review showing that femoral nerve catheter does result in less opioid use, but no difference in pain, length of stay, and postoperative nausea vomiting. So how about persistent pain? Unfortunately, both observational as well as prospective data show that regional analgesia has no effect on either persistent pain or chronic opioid use. So how about regional anesthesia's effect on early mobilization and physiotherapy, as well as improvement in long-term functional outcomes? There are two main categories of functional outcomes. Physical performance-based outcomes such as range of motion, quadricep strength, 6-minute walk test, time up and go test are often used in the early postoperative period due to their objective nature, whereas self-reported based outcomes such as the WOMAC, KOOS, or LEFS are often used in a late postoperative period such as 3 to 6 months or more because they are more related to patients' health-related quality of life. Achieving statistical difference does not equate to a clinical benefit, and we must pay attention to the minimally detectable change for these functional outcomes as well. The impact of regional analgesia on functional outcomes is that of initial functional gain followed by no long-term functional difference. As an example, Nader et al. In the randomized control trial showed that femoral nerve catheter does improve the initial range of motion, but at 6 and 12 months, there's no difference. This pattern is repeated in other studies as well. As another example, in a randomized control trial by Ilfil et al. Comparing 4 days of femoral nerve catheter versus just 1 day followed by sham catheter, that more patients in the 4-day group are able to ambulate over 30 meters. However, this effect disappears from 1 week to 12 months. Indeed, systematic review and meta-analyses show that there's no evidence to suggest regional anesthesia affects long-term functional outcomes. So, what is regional anesthesia's effect on length of stay then? Unfortunately, there is currently no standardized discharge criteria across studies. As an example, one study uses the discharge criteria of pain less than 3, free from IV analgesic, and the ability to ambulate 30 meters or more. At St. Paul's, after conversing with the physiotherapy group, I have determined that there is actually no standardized criteria here as well. Instead, the discharge criteria is tailored individually. For patients living alone, patients would need to be independent in getting in and out of bed, mobilized with walker or crutches, and if there are stairs at home, the ability to climb stairs prior to discharge. If the patient were living with someone, then the patient would only need to do the above with help prior to discharge. Dr. Dan McIsaac conducted a population cohort study using administrative data from Ontario from 2002 to 2013, using the data from over 178,000 patients. He demonstrated that there is a reduction in length of stay, 4.6 versus 4.8 days, with the use of peripheral nerve block. This might not sound like too much, but if you multiply that by over 75,000 TKAs done and $1,600 per hospital bed day stay, then that equates to over $12 million in savings. Unfortunately, this result is not consistent over time. After 2008, overall, peripheral nerve block is associated with an increase in length of stay. This effect stems from the continuous peripheral nerve block group, whereas the single-shot peripheral nerve block group continues to have association with a reduction in length of stay. On the other hand, administrative data from the United States of over 700,000 patients show that peripheral nerve block has no association with a difference in length of hospitalization, but has a slight increase in the cost of hospitalization. Prospectively, there's also conflicting data regarding peripheral nerve block and its effect on discharge readiness, where some studies show an increase in discharge readiness, while others show no difference. And indeed, systematic review and meta-analyses show that in 2014 there were not enough evidence, while in 2019 regional analgesia is associated with a decrease in length of stay, but only in the local infiltrative analgesia group. So at this point, there's no conclusive evidence regarding the length of stay or cost and resource utilization. How about complications? First, we'll talk about fall risk, and then we'll talk about morbidity and mortality associated with neuraxial versus general anesthesia. Many people have the concern that peripheral nerve blockade may lead to falls secondary to motor weakness. Based on the Premier Perspective database from 2006 to 2010 from over 400 hospitals in the United States, there's a 1.6% chance for inpatient fall. Risk factors include older patients, higher comorbidities, and major complications. Spinal appears to be a protective factor. There's no association with peripheral nerve blockade with falls. However, in this database review, we cannot differentiate between single shot versus catheters. On the other hand, from another retrospective review, single-shot femoral nerve block did not increase the risk of falls after TKA. However, continuous femoral nerve block has an increased fall risk with an odds ratio of 4.4. And based on the meta-analysis of 3 prospective randomized control trials, there are 7 falls in 85 patients receiving continuous perineural catheter, whereas there are 0 falls in the placebo group. And the conclusion is that there is a causal relationship between continuous peripheral nerve blockade and the risk of falling after knee and hip arthroplasty. Volunteer study has been done in 2007 looking at peripheral nerve blockade and its impact on falls. Pivoting is noted as the time of highest instability secondary to decreased quadriceps strength, decreased leg stiffness, and decreased lateral stability. Therefore, regional anesthesiologists have moved on to potential motor-sparing blockade such as the adductor canal block as opposed to the femoral nerve block, and IPAC block as opposed to a sciatic nerve block. So how do they compare? The adductor canal block targets the nerve to the vastus medialis as well as the saphenous nerve. In volunteers, the adductor canal block offers more motor-sparing effect compared to the femoral nerve block, and in patients, adductor canal block achieves an improvement to time to adequate mobilization with better time up and go test and better preserved quadriceps strength. However, at this point in time, there is no data that shows that adductor canal block results in less falls compared to femoral nerve block in TKA patients. How about sciatic nerve block versus IPAC block? At this point in time, the effect of sciatic nerve block on falls is understudied. When comparing femoral nerve block with sciatic nerve block versus femoral nerve block alone, sciatic nerve block does offer additional analgesia in the early postoperative period. At this point in time, however, there is no evidence of difference in functional outcomes, falls, or length of stay simply because it is understudied. Now, the theoretical advantage of IPAC block is that it is motor sparing. It targets the articular branches to the posterior knee capsule and thereby potentially avoiding the blockade of the motor branches of sciatic nerve. However, if you look at this study looking at the motor blockade after various blocks, IPAC blocks are still associated with some degree of motor weakness in 40% of the patients. Therefore, despite growing evidence from small randomized control trials that within a multimodal analgesic pathway, the addition of IPAC block may further improve discharge readiness, at this point in time, we do not know its implication in complications such as falls. And finally, many people are in favor of local infiltrative analgesia for its motor-sparing nature. And indeed, based on systematic review and meta-analyses, when comparing with control, Local infiltrative analgesia result in lower pain, opioid consumption, improved early functional outcomes, and reduced length of stay. And when comparing with peripheral nerve blocks such as femoral nerve block and adductor canal block, their effects are equivalent. So the million-dollar question is the performance of peripheral nerve block in addition to local infiltrative analgesia helpful? And based on retrospective and prospective data, the answer is yes. There's an improvement in pain control, opioid consumption, postoperative nausea, vomiting, ambulation, and even sleep when you add adductor canal block in addition to local infiltrative analgesia. Moving on, how does neuraxial anesthesia versus general anesthesia impact the rate of complications? The bottom line is that neuraxial anesthesia outperforms general anesthesia in morbidity and perhaps mortality outcomes. There is even evidence to suggest cost-saving benefits where increasing hospital-level frequency of neuraxial anesthesia use is associated with lower hospitalization costs for knee replacements. The International Consensus on Anesthesia-Related Outcomes After Surgery group has conducted a recent systematic review and meta-analysis looking at patients undergoing primary hip and knee procedures. What they found for TKA is that neuraxial anesthesia offers multiple morbidity benefits. I have highlighted here the ones that have reached statistical significance. Neuraxial anesthesia provides benefit for pulmonary outcomes, renal outcomes, DVT, PE, infections, critical care admission, readmission, and even length of stay. Their conclusion is that provided no contraindications, a primary neuraxial anesthetic technique is preferred for TKA. On the other hand, the ERAS Society has made a separate set of recommendations, where they recommended that modern general anesthesia and neuraxial techniques may both be used as part of multimodal anesthetic regimen. They gave modern general anesthesia the evidence level of moderate and the recommendation grade of strong. Looking closely at the guideline itself, they did concur that large epidemiological studies show that central neuraxial anesthesia is independently associated with better outcomes compared with general anesthesia. However, based on emerging research from 2 single-center randomized controlled trials in established ERAS centers, a modern general anesthetic was comparable with a traditional high-dose neuraxial anesthetic technique, and no clinically significant difference is seen in functional recovery, length of stay, urinary complications, and mobilizations. Therefore, further studies are needed to compare modern general anesthetic and neuraxial anesthesia practices. As a result, we must look at the randomized control trials that support the use of general anesthesia. In these 2 randomized control trials, the patients having TKA were compared using general anesthesia with TIVA using propofol Remi versus spinal anesthetic of 3 mL of bupivacaine 0.5%. Criticisms of these studies are that only the GA group received intraoperative IV oxycodone, whereas the spinal group did not receive any IV analgesic prior to spinal block resolution. This is in the context of fast-track TKA with multimodal analgesia, local infiltrative analgesia, antiemetic, and tranexamic acid. On average, these patients are fulfilling discharge criteria at about 50 hours. So what is the result? One randomized controlled trial found that spinal anesthesia is associated with increased pain, opioid use, and decreased ambulation at 6 hours. This may not be surprising given that the patients did not receive IV analgesic prior to spinal block resolution, and therefore at 6 hours, they would have increased pain, opioid use, and decreased ambulation. There is no differences in hospital length of stay, and in the spinal group, there is a higher incidence of postoperative nausea, vomiting, and dizziness. Now, I must bring your attention to the 3 mL of bupivacaine 0.5% used in the 2 randomized controlled trials aforementioned. If we compare low dose 5 mg versus high dose isobaric bupivacaine, low dose isobaric bupivacaine does result in earlier PACU discharge eligibility in TKA patients. And furthermore, comparing short-acting, such as mepivacaine local anesthetics, with long-acting local anesthetics, such as bupivacaine, short-acting local anesthetics does result in less urinary catheterization and shorter length of stay when used in spinal anesthesia. So in summary, spinal anesthesia does result in decreased complications, and peripheral nerve catheters may increase the incidence of falls. How does regional anesthesia fit into the enhanced recovery protocol? Dr. Dan McIsaac conducted a scoping review looking at the impact of including regional anesthesia in enhanced recovery protocols and concluded that regional anesthesia interventions make substantial contributions to the improved outcomes experienced by patients cared for using enhanced recovery protocols. Although most of this evidence comes from colorectal surgeries, orthopedic surgery contribute a significant portion of the evidence as well. Now looking at the full scope of ERAS Society recommendations for perioperative care in total hip and knee replacement surgeries, we see that they recommend standard anesthetic protocol with modern general anesthesia or neuraxial technique as previously discussed. They recommend the use of local infiltrative analgesia and say that nerve block techniques have not shown clinical superiority over local infiltrative analgesia. But we have previously determined that the use of peripheral nerve block in addition to local infiltrative analgesia does offer additional benefits. They reemphasized the importance of early mobilization. Now, what is the evidence behind implementation of ERAS for TKA? Prospective case series suggested that there is a reduction in mortality and length of stay after the implementation of ERAS for TKA and THA. And here you can see that the length of stay significantly decreased after the ERAS implementation. In addition, in a recently published retrospective cohort study of over 1.5 million patients undergoing TKA or THA, the authors have found that the implementation of ERAS has increased over time. The authors included 8 ERAS variables and categorized patients based on the number of components implemented, high, medium, or low, correlating with over 6, 5 to 6, or less than 5 components implemented. Looking at the figure on the left in the solid blue line, you can see that the number of patients benefiting from high ERAS implementation level has increased over time. And on the figure on the right, in the solid blue line, you can see that the regional anesthesia implementation has remained steady over the past decade. Higher ERAS implementation levels is correlated significantly with a reduction in any complications, cardiopulmonary complications, blood transfusions, and length of stay. And looking specifically at regional anesthesia, you can see that it is correlated with a reduction in any complication, transfusion, but unfortunately, an increase in length of stay. So has the era of outpatient total knee arthroplasty arrived? There has been a 180% increase over the past 5 years in the number of outpatient day surgery TKAs performed in Canada. However, at this moment, there has been conflicting evidence regarding complication rates. There is definitely a cost benefit associated with outpatient TKA, and in the era of COVID-19, outpatient TKA may be increasingly important. This is the proposed St. Paul's Hospital outpatient TKA protocol. We will be implementing multimodal analgesia with a single shot adductor canal block. We are proposing using spinal anesthetic of short-acting lidocaine at a reasonable dose of 3 mL at 2%. We will provide local infiltrative analgesia with antiemetic and provide IV analgesic in the form of hydromorphone prior to the resolution of spinal blockade. Future directions. How does regional anesthesia impact outpatient TKA? What is the impact of regional anesthesia and analgesia on patients in the modern context of ERAS? How does motor-sparing peripheral nerve blockade impact patient-centered outcomes, including complications? What is the cost associated with the provision of regional anesthesia and analgesia for TKA? And what is the optimal regional analgesic technique for TKA? Here are 2 upcoming valuable educational opportunities that I recommend everybody to attend.
Used to be an adventurer like you. Then I took an arrow in the knee.
I used to be an adventurer like you. Then I took an arrow in the knee.
I used to be an adventurer like you. Then I took an arrow in the knee.
Now, with the knowledge that you have gained by listening to this session, we will hopefully be able to help these patients out.